So when I go over these, I get it. And I understand, I'm like, oh, okay. It's not like I look at it and I'm like, I still just don't get how they got it. So, but I think it's still good to talk over with you and kind of
Sure.
maybe see how you would have approached this.
Sure.
Okay. So, in addition to antibiotic therapy now, which of the following is the most appropriate management? So you have a 27-year-old G2P1 at 16 weeks comes to the physician because of moderate pain with urination during the past 2 days. She has no history of serious illness in pregnancy, no history, had been uncomplicated. Examination shows a uterus consistent in size with 16 weeks. Urine culture grows greater than 100,000 colonies of group B strep, sensitive to penicillin, in addition to antibiotic therapy now, which of the following is most appropriate? So looking at this question, when I'm going off of the facts I know, you screen 35 to 37 weeks. However, she's 16 weeks now, and she has group B strep at 16 weeks. And so the rules I know with that are like if they've already had it in the pregnancy, you don't need to screen them at 35 to 37 weeks. But when I was going through the answer choices, screening at the onset of labor, never heard of that, so I didn't choose that. Antibiotic therapy at 35 weeks, yes, if they're positive at 35 weeks, but that's not the next step. And then C-section at 38 weeks, no. I had never really heard of antibiotic therapy during labor. So even though I knew like you technically don't have to screen, I was like, I've never heard of that. So I went with what I knew, but I guess you can give it during labor.
Yeah, I think you worked through this pretty good. The reason why I say that is this is a very specific situation, right? Me personally, I think at one point I knew this, but obviously, when you're talking about OBGYN or any specific shelf, there's going to be guidelines that are very specific for the specialty.
Yeah.
This is one of them, right? Practically in your mind after missing this, the way you should correct it is this, right? Because I think your answer is actually great. Okay. That's reasonable, right? You're like, okay, clinically, you treat it. If it goes away, then you want to screen, right before delivery. So then if it is positive, then you can give it. But it seems like this guideline says that once you've been positive, you already want to give it just in case because group B strep for a kid is like horrendous, right?
Mm-hmm.
So you might as well just give it. And the antibiotic given, right, is going to be just penicillin. So it's not very, it's not there's not many side effects to penicillin. You know what I'm trying to say?
Yeah.
So that's the only thing. That's what I would correct and kind of move forward from this question because it's kind of like one of these guidelines that you didn't know, right? It's like, oh, okay, so if you ever test positive early for group B strep, then what you want to do is during labor, just give them more antibiotics just to be sure. That's it. It's called like prophylactic antibiotics. There's no reason to screen again. That's practically what they're trying to tell you.
Okay.
So nothing, you get what I'm trying to say. You simplify it, right? You're like, okay, there's not much to read into this. You just kind of take it, learn from it, and say, okay, you're never gonna miss this again, right? So
Yeah. So it's the fact that she already had it 16 weeks. So
yep, yep.
just safe kind of as prophylactic as you were saying, you would just do it during labor too.
Yep, during labor too. Yep, because
Okay.
GBS is really bad for the kid, right? So, once you've had it once, then you worry that mom might just be one of the carriers for group B strep. So during delivery, just give them penicillin, so to make sure that baby doesn't get it, right? Because obviously, once baby's born and mom is a carrier for group B strep in that vaginal area, it doesn't matter much, right? So,
Yeah. Right. Okay. All right. Next one. Okay. So this one, which of the following is the most likely diagnosis? So one day after undergoing a C-section for arrest of dilation, 32-year-old woman, G1P1, has a temperature of 100, mild shortness of breath. She received prophylactic antibiotics at delivery. Pulse is 110, respiration is 14, blood pressure 110/72. Breath sounds are decreased bilaterally. No rhonchi, wheezes, or crackles are heard. Examination of breast showed no engorgement or tenderness. Abdominal exam shows a moderately tender fundus. Surgical incision clean and dry. Which of the following? So what I was thinking during this is, and I don't know if it's whatever that that technique is. It's like the things that you hear more recently, that's what you're thinking of. I have never heard of, like, I've heard of atelectasis. I've heard of it, but I haven't come across it in my OB-GYN studying. So what my brain was kind of on was pelvic abscess and septic pelvic thrombophlebitis. Looking back, she doesn't have any pelvic pain.
Exactly.
I do see, because for those two, you have to have a fever. It's usually like right after delivery. And it says here that one day after delivery, she received antibiotics, but yet her temperature was still 100, which is low grade, but she still had 100. And so septic pelvic is refractory to antibiotics. So that's where I was kind of going. But looking back, she doesn't have any pelvic pain, so I guess that rules both of these out. And she, even though she doesn't have any rhonchi, wheezes, whatever, she does have decreased breath sounds.
Sorry, my dog somehow got upstairs, so we just.
No, you're good.
Okay, Bubble. Where are you at? Get used to it. Okay. Yeah, so working through this question, right? I mean, like you said, right? I want you to kind of look overall, right? So she just had a C-section, and I'm going to teach you something too, because they do like asking this. She has a fever after a C-section, right? She had antibiotics at delivery, so you know that for the most part, those antibiotics will cover any infection, right? Like I said, it's usually penicillin, so that should, for the most part, get rid of any abscess or infection, right? But she's tachycardic, her respiratory is fine, her blood pressure is fine, but her breath sounds are decreased bilateral. No rhonchi, wheezes, crackles. Breath shows no engorgement or tenderness, so you're ruling out any kind of breast infection. Abdominal exam shows moderate tender fundus, which is relatively normal after pregnancy. Surgical incision clean and dry. What's the most likely diagnosis? So in my mind, I'm already going, okay, she's post-op C-section. She has a fever. She got antibiotics, right? And her breath sounds are decreased, which is not normal, right? So now I'm thinking, okay, so unlikely bacterial pneumonia, okay, because you're going to hear some kind of crackle wheezes. Endometritis, maybe, but usually you see some kind of, it's usually, oozing, right? Pus from the uterus, right? From below, something like that. So unlikely here. And it's usually they'll say like prolonged ruptures of membranes, which increase risk factors there. Pelvic abscess, like you said, no pelvic pain, like really bad pelvic pain, no pus anywhere. Septic pelvic thrombitis, also pelvic pain. So this is likely atelectasis, right? It has to be a lung issue, which just means like collapse of some of the lung the alveoli, right, causing that. So I'm trying to, let me see if I can share my own screen. Hold on. Post-op fever.
Should I stop sharing?
Yeah, stop sharing real quick. Let me see if I can. Okay.
Yeah.
Okay. So take a look at this picture here if I can blow it up. Okay, so wind, water, walk, wound, and wonder drugs. Okay, the 5 W's is the best mnemonic to remember post-op fever. Okay, first 2 days, wind, so some kind of lung issue, whether it's atelectasis or pneumonia. Water, okay, so UTIs, right, can cause fever post-op day 3 to day 5. Walking, right, so you have no walking, so you can get DVTs and PEs that can cause fever, right, day 4 to day 6. Wound infection, usually day 5 to day 7. And then over 7 days, you're worried about drugs, like certain drug reaction, like serum sickness, things like that. Okay. So a C-section is a surgery, right? And so obviously you haven't done your surgical rotation just yet, but that's kind of what I would be thinking in that situation.
Okay.
Okay.
Cool. Let's see. Okay. Can you see that all right?
Yep.
So, and I guess another thing too, like when approaching these questions is, and maybe that's another thing that UWorld is very like harps on, is all the questions you see are OB-GYN relate, like it's something OB-GYN, and this is something that can happen with pregnant women, but I think I was just so quick to rule it out because I was like, oh, I haven't got any questions on that. Like I usually don't see that. So, which maybe most of the time will work, but just don't totally rule it out
Yeah,
yet.
I mean, okay, so just going back to I mean, this is a good thing that we're discussing now because if you think about it, right, for any kind of specialty, even OB, okay, the thing you have to remember is that pregnant women are at increased risk for certain things too that overlap with either, internal medicine, it overlaps with general surgery, right? So giving you an example is pregnant women are increased risk for gallstones. So they have an increased risk for acute cholecystitis, right? Which is technically like a general surgery, right? Question, but because it's more likely to happen in pregnant women, you can see it on your test. So it's like, oh, what is the management of acute cholecystitis, right? I think the guidelines now say that you should perform the cholecystectomy, right? But some people manage it medically. Trying to think of what else overlaps. Oh yeah, like for instance, like which is a very medicine question, but how do you manage Graves' disease in pregnant women, right? That's a medicine question, but it's going to show up in your OB because pregnant women can have, Graves' disease, right? Or how do you do Hashimoto's, right? Hashimoto's and patients with that are pregnant also. So, or trauma in pregnant women, right? That's fair game, right? So all these things you have to think about that you can't do a narrow scope, right? You understand what I'm trying to say?
Yeah,
You
right.
can't think super narrow where it's like, oh, I just want to do OB, but no overlap with general surgery or whatnot, because, some people use their OB as their family med doctor too, right? So while they're getting, their annual or, pap smear, they're also asking about, oh, how about my nutrition, or how about, what are my labs look like, right? So you can get some family med question also in OB, right? Where non-pregnant woman, just a woman that's showing up to OB clinic asking about, like muscle cramps or whatever it is, right? And so just know that, although 80-90% are isolated to OB, you're still going to get some crossover. So for this question, right, it's a little bit of crossover for, just in general. A C-section is still a surgery, right? And so if you get a C-section, what are your likelihoods of having post-op fever, right? Which is, the thing that we talked about, which is wind, water, walking, wound, and wonder drugs, right? That's what they call them. So
Yeah. Okay. All right. Next question. This one I kind of get, but just to make sure it's solidified. So which of the following is the most likely diagnosis? So you have a 32-year-old woman, 3-day history of spotting, last menstrual period is 5 weeks ago, no medications, normal vitals. She has blood at the cervical os, normal size uterus, no adnexal tenderness, beta HCG is 1,000. She has a positive urine beta HCG test and ultrasound shows a gestational sac and a simple cyst on the right ovary. Which of the following? So I was telling myself, I was like, okay, so last menstrual period 5 weeks ago, her beta HCG is increased. And I was like, but this simple cyst could just be a simple cyst. That doesn't mean it's an ectopic pregnancy. And I was like, I don't think that. But then I was thinking, because sometimes in the question it'll say, like intrauterine ultrasound, and I guess that might give it to you, shows a gestational sac. But I couldn't tell if this was because you see beta HCG increased, you see late period with both ectopic and a normal pregnancy. But I guess what makes this normal is, I guess with ectopic, you usually have pain, like they come in with like some lower abdominal pain.
yeah, well, I mean, I think, yeah, exactly. That's one thing, right? You get pelvic pain, but also on ultrasound, right? They're gonna say that you see a gestational sac in a wrong place, right? So they're not gonna trick you, is what I'm trying to tell you, right? If it's an ectopic pregnancy, they're gonna say the ultrasound showed a gestational sac in the fallopian tube or in the ovary. You understand what I'm trying to say?
Yeah.
So,
So sorry, go ahead.
oh, I was gonna say they say ultrasound shows a gestational sac. You got to assume that it's in the normal location because they're gonna tell you if it's not, right. They're what I'm trying to say. They're not gonna make it like that, right? If it says a gestational sac is seen within the fallopian tube or whatever, then it's an ectopic pregnancy, right? I think for this question you kind of overthought it a little bit, right? Because remember her last menstruation was 5 weeks ago, so her gestational sac is only like a week or 2 weeks old, right?
Mm,
So it's in the normal location.
okay. I know that's where I was, because I was thinking, are they trying to get at with this simple cyst on the right ovary if that's like the
Yeah, but you can tell
state?
the difference if something is a simple cyst or not. Like,
Yeah.
you know what I mean? If you know, if the egg is fertilized, then it's gonna look different. It's a gestational sac. So yeah, a simple cyst is kind of be normal, right? I mean, at any time, right? You know, females have cysts all the time, right?
Yeah.
So
Right. Okay. Okay. That one, this one I get. That one's fine. That one's good. This one, I had ductal papilloma, and this goes back to what I was saying in the beginning about going over these things. And then last second changed it, which always go with your first choice. But what kind, okay, I'll read it. Which of the following most likely diagnosis? So she's 23, she has a 4-day history of bloody discharge from her left nipple, which when I see that, I'm thinking, okay, intraductal papilloma or some kind of malignancy. Her maternal grandmother was diagnosed with breast cancer at 37. Breast exam shows bloody discharge from the left nipple and a 2 millimeter nodule underneath the left areola. So this was an example where I hadn't really seen nodule with intraductal papilloma, but I was thinking the most common thing that I've seen with bloody discharge unilaterally has been that. But then I just overthought it and saw the nodule, and I was like, but usually with cancer, you always have some mass or nodule. So I went with that. But after reading, the answer choices, apparently with an intraductal papilloma, you can have, and 2 millimeters is tiny. So
oh,
maybe,
that is so small. Yeah. So
yeah,
yeah, just the better answer here too, right? Like, you know, she's young, right? And you have to think, okay, think to yourself, most common, right? Young female with unilateral bloody discharge is almost always ductal papilloma. You know what
hmm,
I'm trying to say? And it has to be a nodule because a papilloma is it's a tumor that is papule, right? So you know that there is some kind of nodule involved in it. You know what I'm trying to say?
yeah,
So in breast cancer, right? In theory, can you have it this young? Yeah, you can, but it's usually a little bit older. Also on top of that, right? You'll have different signs like the skin is puckering, the orange diffuse sign, right? For certain kind of cancers, of course, and then you might have lymphadenopathy, right, in your axilla region, right? Weight loss, things like that. So here, just the better answer is going to be ductal papilloma. So
yeah. Okay. All right. This one, I kind of understand, but it's like looking at it, I'm like, why did I choose hepatitis? But in the moment, this is what I was thinking. So which of the following is the most likely diagnosis? So she's 31 years old, 23 weeks, 1-day history of moderate lower abdominal pain, decreased appetite, nausea, temperature 100, blood pressure is not significant. She has moderate tenderness to palpation of right mid abdomen. Uterus is consistent in size. 23-week gestation. No bleeding, fluid discharge. High leukocyte. AST is 45. ALT 48. So before I read this AST and ALT, I was like, this is screaming appendicitis, appendicitis. But then I saw AST, ALT, and I got thrown off. And I was thinking, why would they give me liver values? And when I looked at them, I think the cutoff is like it was like for 48, it was 45, and then 45, it was like 42.
yeah, I
So
think
it's not like,
yeah,
yeah,
hepatitis is going to be in the hundreds, sometimes thousands.
yeah. So I
So
think at the moment I was like, oh, they're elevated. So why would they give you elevated liver enzymes? But technically it's not really that elevated.
yeah, it's not that elevated. It has to be hundreds, and also it doesn't fit with the picture, right? You're not going to have decreased appetite, nausea. Well, maybe no history of serious illness, right? And so hepatitis, you got to be asking yourself why hepatitis, right? You know what I'm trying to say. Also on top of that, you got to ask yourself what kind of hepatitis, right? You can't just say, oh, it's hepatitis, right? What kind? Is it type A, type B, type C, right? E, and so she doesn't really have any risk factors for hepatitis, right? But this question is very tricky, right? Because you might be asking, okay, if it is If it is appendicitis, why does she have right upper quadrant pain?
Mm-hmm.
So do you know why that's the case?
Well, it's weird because here I noticed that here it says of the right mid abdomen, and then here it said lower abdominal pain.
Yeah. Yeah, the reason why is this is why it's good we were having this conversation because there's overlap. Like I said, when you're pregnant, right, your uterus will push your intestines to different locations a little bit, right? So your appendix is slightly elevated up, if that makes sense.
Mm-hmm. Yeah.
So that's why your physical exam is going to be different. And so yeah, this is appendicitis for sure.
Okay. So I think we talked about this, doing step one questions was like same thing. I think I would find one fact and be like, oh, well, that's the determiner, like, and then stick with it. And one thing you told me was, even first of all, like you just said, these levels aren't that high. But even then, it's like, does it fit the whole picture?
Exactly. Exactly. You
Yeah.
got to kind of look at it as a whole, and especially step two even more now, right? Because they care about the whole patient as a whole, right? So I'll give you an example, right? Let's take this patient outside the question. If a 31-year-old female came to you and saw you in clinic at 23 weeks gestation, hepatitis is probably not even on your mind.
Yeah.
You understand what I'm trying to say? Like, if they come to you for abdominal pain, et cetera, that's acute, right? In your mind, you're probably thinking appendicitis, right? It's more common, right? Because for hepatitis to happen, you're like, you would have to be, oh, do you use IV drugs, right? Have you had, Hep C in the past, right? Have you ate something bad? Did you travel, right? Those are the risk factor for hepatitis, right? Or viral hepatitis, at least, right? So, this question doesn't mention any of that, right? The only reason why you thought it was hepatitis is because your AST and ALT values came back slightly elevated, right? Which they're not really that elevated. But in real life, if you saw these labs, you'd be like, you wouldn't care because you would look at the patient overall. So you need to kind of think to yourself, if I saw this patient in real life, am I really thinking hepatitis here? And the answer is probably no, right?
Yeah. And I guess the same thing for this one. I mean, looking at it holistically, like her age,
Yeah, exactly.
like it wouldn't be breast cancer,
Yeah,
more.
you wouldn't jump to that. You know what I'm trying to say? Like if she was like postmenopausal and she has this, then in your mind you should be thinking more than likely this is cancer. You have a young female, right? How many young females do you see? Like, I mean, just the limited amount of time that you've been in OB, which is like 2 months. How many how many young females have come to you? Like, have you seen in clinic that have breast cancer? Like almost none, right?
And yeah,
Yeah, the incidence is so low, right? So why would they test you on breast cancer on a 23-year-old? It seems very far-fetched, you know? The only time that changes if they're like, oh, we took a biopsy, a FNA of the 2 millimeter nodule showing, right, cells that are atypic and past the basement membrane. Then you're like, okay, that's cancer, right? Because they
yeah,
gave you a biopsy. But other than that, clinically, I wouldn't jump to cancer in a 23-year-old, you know? So
right. Yeah.
and I get it, right? They say maternal grandmother was diagnosed with breast cancer at 37. But how many times, I'm just saying, right? How many times have you talked to a patient and asked their history and like, oh yeah, my grandma had breast cancer or my grandma had, it doesn't necessarily translate to a 23, right? Because it's one removed, you know what I mean? But if you're like, oh yeah, my mom had breast cancer at 30, now you're like, oh shoot, that's like very, very close in generation, you know? So that
Yeah.
matters a little bit more. So you have to take it with every piece of information you have to take it relative to the patient itself. So like, I mean, I don't even know how many patients that told me like, oh yeah, my grandma or my grandpa had XYZ cancer, and that's like their only history. In my mind, that doesn't increase your risk for cancer, right? Like in my mind, that's not enough, right? It's like if you told me like, oh, my father, my father, my mother, my grandma, like your uncle, and then it's like, oh man, you have like 7 relatives that had cancer. You're probably some kind of P16 deficient. You know what I mean? Like you're P53, right? Leave for many or something like that. But other than that, it's almost like, you know, history of cancer, like you're not thinking it's significant unless it's multiple lineages. So
Yeah.
just something to think about as a whole.
Right. Okay. That one's fine. Okay, this one. Essentially it's talking about risk factors. And I understand why, but there's a specific question about this topic I wanted to ask.
Sure.
But we can read it. So, which of the following is the strongest predisposing risk factor? So, 42-year-old Nola gravid woman comes to the emergency department. She's a 3-week history of heavy vaginal bleeding. Menarche was at 12. Menses have occurred twice yearly during the past 10 years. Menses previously occurred at regular 28-day intervals. Chronic hypertension. She smokes 1/2 pack of cigarettes daily for 15 years. She's 5'8", 158 pounds, BMI 24, blood pressure 130/80. No abnormalities with pelvic exam. Pelvic ultrasound shows a thickened endometrial stripe. 2 by 2 centimeter simple left adnexal cyst. Results of an endometrial biopsy show well-differentiated endometrial adenocarcinoma. So which of the following? So it's endometrial cancer, which it's essentially with that unopposed estrogen is like the biggest thing.
Yep.
So, and I knew that, and the first thing I thought of was like obesity, which she's not, so rule that out.
You good?
Cigarette smoking, I think in the moment I was just like, wait, I knew that was for cervical cancer. But then I actually found out that it decreases, it says down here, cigarette smoking decreases the risk for endometrial cancer.
I wouldn't take that with a grain of salt, right? I know
Okay.
that's weird because remember when this is just an overall thing. When you do studies like that, right, for risk factor, right, you just think about how the study's done, right? You usually look at a bunch of charts, right? You look at two groups of people that have endometrial carcinoma and people that don't. You know what I'm trying to say? And then what you end up doing is you shotgun approach, right? You go, okay, what do they have? What's their past medical history? What's their social history? Like, you're looking at all these risk factors. And then you do a statistical analysis and go, oh yeah, these are the things that are high risk factors, and then you might accidentally find, oh wait, look, the people that smoke, it seemed like they have less endometrial cancer than the people that don't smoke. You get what I'm saying? So take that with a grain of salt. It doesn't technically decrease it. It just that's how the study showed that data. But truly here, right, when you're looking at it, it's unopposed estrogen. But I mean, you look at it, she has menses twice during the last 10 years. That's not normal, right?
Yeah.
So
Right.
that's the
So
thing. So
yeah, so my question on that was I've seen, as far as risk factors that cause, unopposed estrogen would be anovulation. So the way that works is if you're not ovulating, then you just have like all of this estrogen and you don't have the progesterone after the ovulation to kind of balance out that estrogen. So that's what leads to the unopposed estrogen with anovulation.
yeah, so the way I think of it, right? I mean, that's probably more technical than the way I think of it. The easier way to think of it in my mind is endometrial carcinoma is because the lining of the endometrium doesn't slough off like, these patients don't have a period. So that tissue or blood maintains or gets retained and over and over and over again, right? Because let's say instead of having a normal monthly cycle where you're shedding that endometrial layer, right? Now it's just staying there, right? It's staying there and you're slowly building it up one cell layer at a time thick. And then as those cell layers stay there for a long time, they have an increased risk of mutation. That's how I think of it. Right. And so that's why when you have endometrial hyperplasia, right, meaning that the lining is thicker, you have an increased risk for endometrial adenocarcinoma because those cells are supposed to be sloughed off.
Right.
So,
Okay. See that I feel like
yeah, that,
oh, go ahead.
no, yeah, go ahead. Sorry.
I was gonna say, I feel like anovulation, how you just described it, makes sense. Two other risk factors that I'm trying to understand how those work are nulliparity. So you never been pregnant.
Mm-hmm.
That can lead to unopposed estrogen, and then also early menarche and late menopause. I guess you're just exposed to more estrogen and all of those.
I wouldn't say like again, I try to think of it as the layer, right? So let's talk about if you have more periods, right? Before you like late menopause, right? That
Yeah.
means that lining is still not, it's still building, right? So you have increased chance, right? Because once you hit menopause, you don't really have an endometrial lining, right? You don't create your lining anymore because you don't have periods, meaning I mean you have very low chance of having endometrial carcinoma. If anything, the endometrial lining is too thin. Does that make sense?
Yeah.
Because once you hit menopause, right, you're not really you can't make babies anymore, right? So there's really no reason to maintain that endometrial lining because the endometrial lining on an evolutionary standpoint is just meant for a good habitable environment for the or for a fertilized egg to implant and grow, right? So there's really no once you hit menopause, I mean, I think the risk of endometrial carcinoma is probably like almost like zero, right? I'm not saying it's completely zero because in medicine, nothing is absolute, right? So that makes sense. The older the later you have menopause, then of course, right, you just have more chance of endometrial carcinoma than a normal person because you still have that lining. Um, what was the other one? Early menarche or late menarche? I can't remember.
Early. So I
Yeah,
guess
early. Yeah, so
you're
you have more periods, right? A longer time of that endometrial lining. That makes sense, right? And then what was the other one?
nulliparity, so you've never had
Yeah,
kids.
so having kids is actually ironic. I can't remember exact, but kids almost like it kind of like um that layer becomes stable for the development of a kid. So during that 9 months, right, that layer is kind of stable to kind of maintain the development of the child, the fetus, right? So during those 9 months, you're not really going to get endometrial carcinoma, right? And so also I think it like refreshes probably that lining in a sense, right? Because once you have your kid that sloughs off, then it takes time to regrow, and so it kind of resets it, right? Because cancer happens because of a prolonged amount of old cells, if that makes sense. That's how I think of cancer, right? Cancer is you have cells that are old that keep that keep growing, that they mutate and then become cancer, right? And so if you refresh it, like you hit the reboot button of that endometrial lining, then you won't, you have a lower chance of endometrial cancer.
Okay.
And then also to kind of piggyback off that same idea, that's why for skin, so something, do you know what dermabrasion is for skin?
Mm-hmm. Yeah.
Yeah, so if you look at chemical peels or physical dermabrasion, it decreases the chance of you having skin cancer, and it's the same idea. You're sloughing off old cells and you're having new ones grow back, and so the old cells don't stay there for a long time. So that's the whole idea. So people that do dermabrasions or chemical peels, they have a less likelihood of getting skin cancer. So same idea.
Okay. Gotcha. I think so for this question, so this is like one of the last ones, but let's see, mass complete. Okay. Diagnosis. 27-year-old comes to the physician 2 weeks after noticing a mass in her right breast. Her child was born 1 year ago following uncomplicated pregnancy delivery. Discontinued breastfeeding 4 weeks ago. She has no history of serious illness, no operative procedures. Vital signs normal. Examination of right breast shows a 3 centimeter, slightly tender, non-erythematous, mobile, fluctuant mass. The remainder of the physical examination shows no abnormalities. Fine needle aspiration yields 5 milliliters of clear fluid and then completely resolves, which is the following. So it's galactocele. Galactocele, I know you get during breastfeeding or you just finished breastfeeding. Essentially, it's like a clogged duct because of
Yeah. Mm-hmm.
milk that's there.
Mm-hmm.
But when I saw clear fluid, because usually it's a milky fluid. So when I saw clear fluid, I wasn't even thinking galactocele, but I guess it can be clear or milky. But then looking at what I chose, it's not erythematous.
Yeah,
Which
yeah. So
those are.
yeah, so for a breast abscess, it's gonna be super, super tender, right? You can have some systemic issues too. Like for instance, you could have fever, right, for a breast abscess, right? And also on top of that, when you do a fine needle aspiration, ironically, if it comes back like milky color, then that can also be a breast abscess too, because pus is like white, right? So actually a clear fluid, right? Clear, like clearish, milkish color, right? Because breast abscess probably be a little bit more chunky, if that makes sense. I'm not sure. Have you seen somebody drain an abscess by any chance? Any kind of abscess yet?
Mm-mm.
It's like popping a pimple practically. So when you pop a pimple, there's like, that the purulent white stuff that's thick and chunky. Yeah. So that's more abscess color. So a clear fluid, if anything, that's going to roll out your abscess. There's no way that's going to be an abscess. But clear fluid for a galactocele, right? Because milk can be a little bit watery, right? So just so you know.
Okay.
Yeah. The
Yeah,
rest don't really make sense.
because I think even though it says slightly tender, I was like, oh, abscess is tender, but this also kind of gave it away too, because usually they're tender, red, swollen, all that kind of stuff. Um, but what you're saying is because it's clear fluid, you can still have that with the galactocele. It's usually milky clear versus breast abscess is more of that like pus kind of.
Yeah, it's gonna be
Or,
pus, thick, white, definitely white. So yeah, discontinued, yeah, breastfeeding 4 weeks ago. So it's within the time frame. It's so early. Unlikely you're gonna have a random breast abscess, right?
yeah, okay. Something else I was going, oh, because I think UWorld had a question. And yeah, it was a galactocele and it was a brown discharge. And I was thinking brown, and it said it could be a galactocele could be like milky brown, I guess, whatever. So I think I was thinking on those terms, but now I know it can be clear as
Yeah,
well.
just I mean, I would say this, right? The color of the FNA, right? The color of the FNA has to be related to the clinical setting. Okay. So you can't just, by a color say it's something, right? I mean, I think people when they take tests, they're trying to categorize like, oh, I aspirated something, it looks like this, it has to be this, right? I mean, because things can surprise you of what color it comes out as, right? So you have to relate it to the clinical setting, right? Giving you an example, I'm going to give you a crazy one. There was a patient like years ago that I did a fine needle aspiration on the neck, and it came out crystal clear in the neck. Okay. um crystal clear, like, I mean, it's as clear as ever, and that's very strange in the neck. And then but she had a history of a spine surgery, so I was like, there's no way, but what are the odds? So I sent that fluid for CSF and it came back positive, right? But what I'm trying to say is things can surprise you, right? Like the color can surprise you, things, but it has to fit with the clinical setting. If she never had spine surgery, I would never test that for CSF, even though it's clear. You understand what I'm trying to say?
Yeah,
So in this scenario, just take out, like, it doesn't matter what the color of the fluid is, right? But her 4 weeks of breastfeeding, right? 2 weeks ago, 2 weeks ago, she noticed a breast mass, right? That's fluctuant, meaning it's fluid filled, right? It's only slightly tender. She doesn't have fever. It's non-erythematous, right? So that means 2 weeks after she stopped breastfeeding, she had this like fluid filled sac, right? Without knowing the FNA, the answer should be galactocele. Doesn't matter what color it comes out. You know what I'm trying to say?
yeah. Once again, full picture.
Yep, full picture. Step two is all about full picture. One thing shouldn't dissuade you from an answer choice.
Yeah. Okay. No, that's fine. That's fine. That's good. I know this looks like a lot. A lot of miss. I think the rest are fine.